so in our last 3 minutes, I want each of you, with respect to your talk, to talk about to just quickly say two promising things on the horizon in terms of clinical trials, investigational therapies, things that are here now that will be refined. And so I'll go around. So we'll start with Dr. Cooper.
Thanks, and thanks so much for the opportunity to participate in this great workshop. I think one thing I probably didn't emphasize enough is that trastuzumab deruxtecan is the only approved therapy right now as an ADC for lung cancer, and so other ADCs, which I've mentioned, are all sort of investigational and coming. But I think that the approvals are eagerly awaited, and so we're looking for the approvals both in non-small cell lung cancer and small cell lung cancer to be coming in the coming couple of years.
Dr. Chin?
Yeah, I think that something that I'm really excited to see more about is using these targeted therapies in the neoadjuvant space. So for patients who are surgically resectable, we now can consider, in the absence of one of these mutations, chemoimmunotherapy. But again, with such effective targeted therapies, is there a role for using them prior to surgery? I think we're seeing more and more studies come out. So I'm certainly looking forward to that. And I'm also looking forward to see, can we at least compile, from different institutions work together to look at some of these less common mutations. So talk about EGFR and ALK, there's ROS1, RET, MET, and what is the role of the targeted therapies for those mutations in the early stage?
Excellent answer. So Dr. Roto is next on my camera,
Great.
on my screen.
So I'm going to talk about, I guess, emerging therapies, right? So what do I hope we're going to have available in the next year for EGFR that maybe isn't available today without a clinical trial? And the two things I'll highlight are, one, those EGFR exon 20 insertion active pills. Exon 20 insertions have always lagged behind the more common mutations because they're harder to treat. There are some drugs showing really nice responses in clinical trials, pretty far along in clinical trials. So I'm hoping these are going to be available for our patients who can't be on a trial. So that's one. And two, we've talked about antibody-drug conjugates. There are several antibody-drug conjugates which have shown really nice activity for EGFR lung cancer at resistance to things like osimertinib, which I think are going to add to our list of effective options for these patients. And again, I'll be shocked if they're not available in the next year outside of clinical trials. So both I'm very hopeful on for the future.
Exactly, and we don't want to shock Dr. Roto. So then we'll go to Dr. Shields for our final.
Yes, absolutely. So, thank you for the opportunity to speak today. An exciting revolution for small cell lung cancer. I think we have seen, obviously, the antibody-drug conjugates with these Trojan horses, this molecular glue with tarlatamab, immunotherapy with training the immune system with durvalumab and limited stage. We're seeing that really the shift is now, how do we use these therapies earlier? And so that whether that is in the first line setting with novel combinations that are being actively studied with these new drugs, or even in limited stage. And so I think staying tuned to seeing how we can sequence and when is the right time for each of these approaches. I think that's one is what is the right sequence? How do these chips fall appropriately, and when do we use what and for what patients? I think the second thing that really speaks to it is that for small cell lung cancer, patients are living longer. They are being cured. They're winning the victory on this disease. And so it is our job as oncologists and your cancer team to help support you, to have you see palliative care early, to address cancer-related symptoms early, to work with a dietitian, and to have all of that support to stay on therapy. Considering a drug called trilaciclib or Cosela, which is a supportive care medicine, to help reduce the risk of those side effects of chemotherapy, like lowering of the blood counts or anemia or infections that might end you up in the hospital and you have to delay therapy, which is what you ultimately need. And so how can we support you? This is a marathon, not a sprint. And we want patients living longer, having happier lives, and really tolerating therapies for the long term, and hopefully to reach cures for every patient with small cell. So I think really exciting time. Thank you.
Yeah, and I echo everything you all said. I cannot say anything articulated any better. And I think I just want to thank the four of you for joining us. You truly are people who are helping patients live longer, and it's always a pleasure to learn from all of you.